I'm Peyton. I'm an internal medicine doctor here at Arkansas Heart Hospital, and we're going to talk a little about COVID-19, and which I'm sure is occupying the majority of all of our lives right now. And so just a little bit about myself. I am from Arkansas originally. I grew up down in Magnolia. I see a lot of familiar faces in here from around the state. I did my undergrad down at Louisiana Tech, but otherwise I've done all my medical training here in Little Rock and been at the Heart Hospital for about 3 years. I've done a few different things since joining on there. Originally, I was in our clinic seeing patients and doing cardiac rehab. And like many of you in the room, probably COVID-19 has kind of shifted gears on all of our practices. And currently, I'm just seeing COVID patients in our COVID care unit in the hospital. And so to start off, I just wanted to talk a little about the actual virus that causes COVID-19. This is a diagram of that virus. The main thing I want to draw your attention to on this SARS-CoV-2 particle is the spike proteins, which are the little red parts sticking out of the virus. We'll come back to this a little later, but these spike proteins are actually the part of the virus that we target a lot of our therapies at, and really a lot of our interventions are geared towards. So some of you, I'm sure, have noticed some trends in COVID-19 patients that get severely ill. Basically, the way I've started looking at it is any patient that has a organ system dysfunction that causes like chronic impairment in that organ system, that basically can make the body weaker for all of its organ systems functioning together as a whole. So people with things like COPD, CHF, CAD, diabetes, obesity, CKD, definitely anybody that's immunocompromised or that has an active malignancy. The caveat to this slide that I'd like to point out, though, is that time and time again, I think we're all reminded that COVID has a mind of its own. It picks and chooses who it wants to affect severely. Many of our patients that I really think are going to do well end up declining, and a lot of the patients that you think are going to be a complete train wreck with COVID end up walking out of the unit a couple days later doing just fine. And so I think that these are important risk factors, but really I've started telling our patients that we've learned not to try to predict the future when they're in the hospital with COVID. So just kind of the overview of how COVID usually affects our patients. Most of the time when we see patients in the hospital, we're dealing with these right two columns, the severe and critical illness portions of COVID. You might see some patients in the clinic falling into the moderate disease category, where they're having mild symptoms at home, but not needing things like oxygen or any type of support in the hospital. And so most of those patients are still in the viral replication phase of COVID, where they're actually still kind of gearing up in the disease. And that is the perfect time, if your patient's qualified, to hit them with things like monoclonal antibody infusions to try to slow the disease down, to prevent it from progressing to severe or critical illness where they are going to need hospitalization. And so around that time period, you're dealing mainly with viral replication. And then a lot of the patients, especially the critically ill ones in the hospital, are actually kind of shifting more towards the inflammatory issues with COVID and the cytokine storm and things like that. And so almost all the patients that we admit to the hospital are severe or critically ill. And those patients you treat pretty much with an order set of things at this point, depending their availability. And those things include remdesivir, dexamethasone, and vitamin supplementation and anticoagulation. And so I just wanted to talk about a couple of the things, the way COVID affects the body. This is a slide just of the typical chest x-ray that patients with COVID that are moderately to critically ill come in with. You can see the kind of patchy infiltrates just surrounding the lungs. The majority of patients that get hospitalized have appearances similar to this. Some of them will have just like a complete whiteout though, like ARDS type picture. And this is a CT scan slice of a patient with COVID lung injury. And a lot of times I can help it kind of sink into these patients that really don't feel horrible at the time, but that are needing a ton of oxygen. I tell them, it's like a tornado's going through your lungs right now. And that's kind of what we're left with after this disease. And I've seen COVID really affect all the organ systems in the body. I know we're at the heart hospital and a lot of our patients have cardiac comorbidities to begin with. And so a lot of these patients will have flare-ups in their CHF during COVID. And they'll also sometimes have like non-ST elevation MIs. I have had a couple patients actually have a true STEMI. And that's usually at the times I've seen it, where they're basically in multi-organ failure, and that's kind of the last straw usually before they eventually pass away. So there's a couple treatments that over the course of a few of the trials have shown proven mortality benefit. A lot of the other treatments we've been kind of back and forth on since the pandemic began. But one of the main ones that has definitely shown benefit is dexamethasone. And if dexamethasone is unavailable, kind of any type of steroid basically, to try to knock down the progression in the lung disease. And so this is a little graphic from one of the main studies in New England Journal that shows the overall benefit in mortality with dexamethasone. And the big key factor to when you start dexamethasone on your patients or any steroid is whether or not they're needing supplemental oxygen. And so, I think the thought on that is if your patient's not needing additional oxygen therapy, it's probably better to keep them off steroids to let their immune system do their thing. But if they're getting to the point to where they need oxygen, I think it's fair to say that their lungs are kind of starting to attack themselves, and they could benefit from steroids to try to knock that down. The other drug that has kind of initially gone back and forth on whether to use it or not, I think the general consensus at this point is there is a mortality benefit with tocilizumab. The brand name of this drug is Actemra. It was originally a drug that was used for rheumatologic patients and some chemotherapy patients. It's an IL-6 inhibitor, so what the thought behind tocilizumab is that you're cutting off the cytokine storm and trying to prevent that rapid progression in patients declining. And so the times when it's really good to use this drug is your patient that's in the hospital, that might come in initially needing 2 or 3 liters of oxygen, but then is just starting to rapidly decline and their oxygen needs are shooting up. They're heading towards BiPAP or Vapotherm, or patients that you think might eventually need the vent or ECMO. And the idea with this drug is to give it to kind of stop that progression. And I really have personally seen a lot of benefit in giving this medication, and it has stopped a lot of patients ending up on the ventilator. The caveat to this right now is this drug has gotten extremely hard to get in the last couple weeks. And so I know right now many of the hospitals in Arkansas, if they're getting any, it might be a couple vials a month. And so it's really gotten difficult to get this medication, but if you can get it, it definitely works. Then another thing that I'd say the majority of my questions from patients on the outside of the hospital are about vaccines. And so I did just want to throw a slide or two in here about how these mRNA vaccines work, just kind of the high points to help you be able to answer some of your patients' questions. And so the broad overview of these vaccines is you're getting injected with just a little bit of mRNA that actually codes for those spike proteins that we talked about earlier on the virus. And so when you're injected with these mRNA particles, they're taken into your cells so that your cells can produce antibodies to these spike proteins. So the idea is that you're left with kind of circulating antibodies to the COVID virus and these spike proteins that could attack it if you're infected with it. One of the big questions I've gotten from patients is the idea of it altering your DNA or, changing your genetic makeup and things like that. And there's actually a really straightforward way to kind of shoot that down if your patients are asking you about that. And the big problem with that theory is that the mRNA that you're taking in actually never ends up in the nucleus of your cells. and that's where your DNA is housed. And so it should, in theory, never be able to interact with those molecules. And so most of that activity is done out on the ribosomes, and it's never interacting with the actual DNA molecules. The vaccines, I also want to just hint on, I think we all in here probably realize that they are effective. This just kind of briefly looks at the Pfizer and Moderna vaccines, the most common ones that we give here. And the kind of combination effectiveness is 91% on those vaccines. And this also shows that it decreases time with fever, it decreases your viral load, it decreases time that you feel ill or in the hospital, and days you have to miss from work. And the big, the hot news right now is the Delta variant. And so I would like to point out that these vaccines do still have activity against the Delta variant. The kickers with that is that there's an even greater need to have 2 vaccines than with the Alpha variant of COVID. And so you do get protection from the vaccines, but not near as good after the first vaccine in a series as you would with the original COVID strain. But we are still seeing, personally, I've had several patients over the last couple of weeks that have started trickling in that are vaccinated, that I'm assuming have the Delta strain of COVID. I did not see hardly any vaccinated patients coming in the first go around of last year at this time. So I do think that we're having more breakthrough cases, but the big thing that I've also noticed is those patients are not dying. Most of them that get admitted are rapidly improving over a couple days. Even if they need things like high flow oxygen, they're rapidly improving and being able to go home. They're not dying in the hospital. And so to kind of sum things up, I just wanted to hit on a couple high points. These are kind of the way I think about these patients when I get a call from the ER. The first thing that you need to think about is whether or not to admit the patient. And are they needing things like supplemental oxygen? That's the main thing that keeps patients in the hospital, unless they're just really dehydrated from vomiting or things like that. But if you're discharging the patient, there's a really good chance that they are now a candidate for a monoclonal antibody infusion, and that's to try to prevent them from bouncing back and needing admission. And so that if you have access to those infusions, they really do keep a lot of patients out of the hospital. And then for the patients that you're admitting, the mainstay of therapy at this point is to start dexamethasone, remdesivir, DVT prophylaxis, and vitamin supplementation if they're needing supplemental oxygen or an increase in their home O2 requirement. If their O2 requirement is fastly increasing or rapidly increasing, if you have access, give them a dose of Actemra, because that really can help out that progression. And then always remember and explain to your patients that COVID has a mind of its own. And so, after giving them all of those things, you kind of just really have to sit back and hope for the best and provide the best supportive care you can, because sometimes it seems like some of these patients are predestined to do good or bad with COVID. And so I'm always upfront with the patients, and I think that's the best thing we can do when we're kind of explaining to them the course to expect. All right, thank you for your time.